at the UN's 2023 High-Level Political Forum organized by the Chronic Poverty Advisory Network, CPAN. This event, entitled How Can We Avoid Pandemic Poverty in the Future, will explore countries' different responses to the pandemic, what mitigating measures were and can be taken in the future, and with what results. And we will also consider how the WHO's Pandemic Preparedness Treaty can take account of such needs and learning from the COVID-19 pandemic. My name is Peter Taylor. I am Director of Research at the Institute of Development Studies, IDS, in the United Kingdom. I'm also Director of the COVID Collective, a social science research platform supported by the UK's Foreign, Commonwealth and Development Office, which offers rapid social science research to inform decision-making on some of the most pressing development challenges related to COVID-19, and which supported some of the research that will also be discussed in the session. So welcome to all those participating online. A few quick logistical points. The webinar will be recorded. There will be live English to Spanish and Spanish to English translation throughout the webinar. So those attending may choose which language option you would like, and this should pop up on your screens either at the bottom or the top. So please choose Spanish or English as you wish. Please leave your comments and questions either in the chat or in the Q&A box, and there will be time, we hope, for the panelists to answer those at the end. And if you're happy to be contacted after the event, we'll be sharing some excellent resources with you. And if you'd like to tweet about anything during the event, please do so and use the hashtag #pandemicpoverty on Twitter. So why is this session important? Well, the COVID-19 pandemic was responsible for high but also highly varied mortality and illness, both of which also had major well-being consequences for affected individuals, households, and communities. Policy responses to the pandemic also severely disrupted economies and social life, and all these together have led to substantial reversals in social and economic progress, especially for poor and vulnerable people in low and middle income countries. But this is also a time of hope and opportunity. As we'll hear today, governments, communities, and the organizations they work with have all helped to identify strategies and approaches to address the short and midterm needs and challenges generated by the pandemic and other interconnecting crises. We're learning together about what could lead to a genuine transformation of ideas, policies, programs, and practices. And we're seeing collective urgency in fostering collaborative and comparative learning across the experience of different countries and localities, and in finding ways to avoid returning to conditions that do not serve us well in the future. Now, in today's panel, we have a truly global and excellent group of speakers who will bring different examples of efforts to address the impact of the pandemic on poverty, resilience, and vulnerability. Firstly, reflecting on the great diversity of policy responses, we have three contrasting country experiences. Firstly, Nicaragua, presented by the Honorable Minister of Health of Nicaragua, Her Excellency Dr. Marta Reyes Alvarez. Nicaragua had made huge investments in hospitals and community-based health over more than a decade prior to the pandemic, and was consequently freed up from needing to panic and could instead decide more logically how to respond to COVID-19. We'll then hear a case study from Cambodia, and I imagine that will be presented by Dr. Andrew Shepherd, who is the director of the Chronic Poverty Advisory Network. And this will talk about where conservative macroeconomic management combined with a long-term populist government meant it could attempt to mitigate the worst effects of the restrictions it imposed. And then we'll hear from Bangladesh, presented by Dr. Asif Mohammed Shahan from BRAC University Institute of Governance and Development, BIGD, about how Bangladesh adapted its management of the pandemic to its local contexts as it went along. And as the presentations will show, all the examples had positive points as well as less successful aspects, but together they indicate how the global response to the pandemic needed to be context-specific, focused on minimizing inequalities and continuing with development policies and programs during a crisis. Drawing the lessons from these and other diverse responses will undoubtedly be a continuing venture for researchers as policymakers move on to managing the next crisis in this polycrisis world that we inhabit. And then we're going to follow the country presentations with a presentation by Dr. Vidya Diwakar, a research fellow at IDS. And she will speak about the Chronic Poverty Report on Pandemic Poverty, which is a first attempt to produce a report of this kind. We will then hear a presentation by Catherine Grant, Research Officer at IDS, on the People's Agenda on Pandemic Preparedness. And finally, we'll hear from Professor Toby Green in a pre-recorded video due to a scheduling conflict. He's Professor of Pre-Colonial and Lusophone African History and Culture at King's College London, and he will be speaking on the report from a group of scholars at Collateral Global on the management of the pandemic. Following the presentations, we'll also hear from two eminent discussants to share their reflections on what's been presented. Bushra Ebadi, Research Associate at the UN University, and Dr. Nda Konan Michel Yao, Director of the Department of Strategic Health Operations at the WHO. So I think you'll agree, a really fantastic and global group of speakers, and we'll begin hearing about experiences from 3 countries, and I'd like to invite the Honourable Minister of Health of Nicaragua, Her Excellency Dr. Reyes Alvarez, to start us off. Please, welcome.
Good morning, everyone. I hope you are hearing us. We are going to share our experience on addressing the pandemic in Nicaragua. For us, it's been very important to establish some information about our country. It's in Central America. It has an area of 130,000 square kilometers and a population of 6.7 million. The model we had to address the pandemic was the family health and community health model from 2007, and the basis, it's 2,700 sectors that are being attended by health teams, family and community health teams that serve between 600 and 1,000 families each, with 38,500 health resources and a community network integrated by 60,000 members. The main objective of our government was recovering the health. Besides this basis, we have 75 hospitals, 12 national hospitals, 7 regional hospitals, 12 distrital hospitals, and 42 primary hospitals. We have 141 health centers, 1,333 health points, and 5,600 base houses, as we call them. We have 181 maternities and 93 houses for people with special needs, 1 natural medicine institute and complementary therapies, and 78 mobile clinics that guarantee having health services in the most remote communities. Our family and community health model is the response of our government to the health situation of our people. One of the main focuses is the promotion of health and prevention of illnesses, attention to the people that are ill, offering dignified, high quality and free services. This integral model has been able of answering different pandemics such as H1N1 influenza, chikungunya virus, Zika virus, leptospirosis, as well as COVID-19. Our preparation started in January 2020, 2 months earlier to the first case of COVID-19. Started with an interinstitutional commission on the 30th of January 2020. We had a preparation protocol and response protocol for COVID-19. Since the 9th of February, we strengthened the epidemiologic unities in the public and private sectors. In the 13 entry points of the country, we strengthened the preventive measures with a permanent communication plan. We established 19 hospitals to attend to COVID-19 cases at national level. We created courses for health people working on the health sector, and we started focusing on the organizational model. We created a national commission, communication plan for the health, communitary and family health, with economical actions to mitigate the negative effects from the pandemic and having an immediate response to the problems. We also developed a focus on networks as effect of the organizational model for addressing the cases that were appearing. We also coordinated public and private sectors to have a joint action towards the pandemic. Other important measures was improving the capacity, monitoring capacities, and a constant presence of the teams of the health ministry. We also ensured having a contingency plan with doctors, strengthening the tension and on each health unit. We strengthened as well the primary sector and hospitals for giving an adequate answers, and developed teams that were multidisciplinary and that were present in the different answer teams created for the pandemic response. We found that the initial attention of the respiratory cases were fundamental. We made visits house by house to being able of detecting first cases that we could refer to other health units. We had an uninterrupted protection, personal protection equipment, medical equipment, and we established tele equipment, being able to take information about the virus to the population as a whole. From the development of actions standpoint, we had a primary response on the public and private sector. We had vitals monitoring, and as we said before, the network of family and community health, as well as the community leaders, made almost 5 million visits to households to being able of detecting on the early phases only instances of the illness and being able of saving lives. We made we had a sanitization with chlorine, and where there were a high population concentrations, being markets, public transports, and we articulated all the measures with the different sectors of the territory, from the grassroots level to the top. There were other important aspects that were the in March of 2001, we got the first vaccines with help of the Russian Federation. In the first wave, we vaccinated chronic persons with chronic illnesses and people over 60 years. Then on the second wave, we vaccinated people between 50 and 59 years and people working on essential jobs as firemen, people working on the borders, policemen, and then on the third and fourth phase, the rest of the population. On the initial phases, we didn't have enough vaccines for everyone. COVAX didn't give us the promised vaccines. We had to buy and depend on the donation of vaccines to protect our population, and this allowed us to have the 96% of the population with the whole scheme, thanks to the help of WHO. Our model of family and community health that was established since 2007 proved to be a very important model to mitigate the effects of the pandemic, as well as the strengthening of the number of health workers, being it the table of workers during the pandemic. The budget allocated to health that was strengthened was a very strong, a very important pillar to being able to answer to the pandemic, as well as the preparation of people working on the health sector and the strengthening of the infrastructure. Second, the actions that were aimed to follow international protocols, keeping active our economy, were very important to have a singular answer thanks to the our strategy to answer to the COVID-19 pandemic. Thank you very much for your attention.
Your Excellency, thank you very much. Very interesting to hear about the level of preparation and the way in which you were able to address the needs of the people and during the pandemic at such scale and at such speed. Thank you. We'll have a lot to reflect on as we continue the conversation. Let's now turn to Cambodia, and I'll invite Andrew Shepherd, my IDS colleague, to share some reflections from this.
Thank you very much, Peter, and thank you very much, Your Excellency, for your presentation on Nicaragua. Before I speak about Cambodia, I would just like to add something about Nicaragua, because the Nicaraguan case features in the Chronic Poverty Report that my colleague Vidya Diwakar will be talking about in a few minutes. It's an exceptional case, and that is why we asked Her Excellency to make the presentation today. The kind of preparation and investment over many years which Nicaragua has made in health systems, especially at the community and regional levels, is quite exceptional. And this meant that when the pandemic came, Nicaragua, unlike many countries, did not panic. There was no need to panic because there was no fear that the health system would be overwhelmed. This meant that arguments in Nicaragua about needing to keep the economy open, as Her Excellency mentioned, could be heard. So there were no or very few lockdowns, and restrictions were at a much lower level. Restrictions on movement and borders and schools and so on were at a much lower level, and people were given choices. So, for example, schools remained open, and parents could choose whether or not to send their children to school. And all of this was a result of the intense investment in health systems and the preparation for the pandemic that Nicaragua was able to make. And I think it's good to also point out that Nicaragua was able to maintain positive economic growth during the pandemic, which is quite exceptional among many countries. While most countries were busy adopting restrictions on movement, on people's movement, on markets, closing schools, restricting traffic across borders, one of the consequences of all these restrictions was that, of course, people lost their livelihoods or were able to earn less money, and social and economic progress was interrupted. Cambodia was a country which managed to balance these restrictions with mitigating measures to prevent people becoming poor or even destitute during the pandemic. And it was able to do this. Of course, its response was not perfect. No country's response was perfect during the pandemic. I think we can all agree on that. But its response was better than most or many countries at its level of income. So there are several reasons for this. One was that Cambodia had a good record in terms of macroeconomic management. So when the pandemic hit, it had budgetary resources which it could call on to manage the disaster. So it was able to pay wage subsidies, furlough payments in the tourism and garments sectors through until September 2021. It was able to expand social protection to include new beneficiaries, to develop new schemes even. And similar to Nicaragua, it was able to invest very quickly in vaccines, and it had the community health infrastructure to develop a first-class vaccination program. Apparently, it was second to none in Asia. So Cambodia, for a long time, was ahead of most countries in vaccination. A second reason for Cambodia's strong response was that its disaster management is very well institutionalized. It's the disaster management institutions, if you like, and processes. It has a strong legal basis, a law which was revised in 2015, and it has a National Disaster Management Committee chaired by the Prime Minister and including all the line ministries, so that in the room where decisions were made about how to manage the pandemic were many interests represented, economic and social, as well as health. And there were discussions and debates about how to manage the pandemic in that forum. There is a working group of the ministries on disaster management, and at province and district level, there are well-established committees which have been operating over long periods of time. And these actually include representation from the Red Cross as well as from the local authorities. So these were some good institutional bases for balancing the restrictions which Cambodia introduced, many of which were decentralized to those province and district areas, balancing these with mitigating measures. And I'll just speak about a couple of the mitigating measures that were introduced. So social protection was one, where there was a significant increase in public expenditure during the pandemic. And Cambodia has, before the pandemic, it had reorganized and coordinated its social protection efforts, formed a National Social Protection Council to oversee it. And in terms of targeting, reaching the right people, it was able to adapt a strong targeting system, its so-called ID-poor system. And it enabled, this system was expanded to reach people who had previously not been classified as poor, but were in a bad situation during the pandemic. And this continued throughout the pandemic. So even in September 2022, social protection was being extended to victims of inflation, the next crisis which was coming along. I'll talk a little bit about education as well, where it became clear that a digital response, remote education, was not going to be enough, despite the high mobile phone coverage which exists in rural, even in rural Cambodia. So the Ministry of Education worked very hard to introduce paper-based learning materials that children who could not get access to digital communication means could use, and also train teachers in the use of digital education, train them also to develop small group teaching methods where the teachers went out to work with small groups of children and use text messages to communicate with the parents of those small groups. Now, none of this was perfect. And for example, the education measures took quite a long time to come through the system. So there were many years of learning still lost despite these measures. Schools were closed for something like 250 days. So there was a lot of damage there, but it was a very creative process in Cambodia. There were other areas in which there were still problems despite the efforts of the authorities. So, for example, in household debt management, there were some measures taken to postpone repayment of household debts to creditors. But at the same time, the interest on those payments was not waived. So these measures they were not hugely popular. And taking new loans to pay old ones was very common in Cambodia before the pandemic, and it became even more common during the pandemic. But this is something which globally needs to be reviewed, I think, to the issue of managing household debt during the pandemic. So these are a few things, Peter. Just to keep it short, I think one might ask a broader question about why Cambodia was able to manage this kind of balancing act between the restrictions and the mitigating measures. It has a long-term political settlement in which power is very centralized, although the opposition has gained a certain amount of traction and popularity, but the regime itself has what you might describe as quite narrow social foundations. So there's a very interesting political dynamic in Cambodia, which we probably don't have time to go into, but which must lie behind the success of Cambodia in this respect. Thank you very much.
Right, thank you, Andrew. Again, another really interesting story from a very different context. And in that spirit, let us continue now to another national context, to Bangladesh. And I'll invite Dr. Asif Mohammed Shahan from BRAC University Institute of Governance and Development to share your experiences with us, please.
Thank you. Let me just make the screen. Thank you. Thanks a lot. I hope that everyone can see the screen.
Yes, very clear.
All right. Thank you. Thanks a lot for inviting me to this very important session. Since we are talking about the COVID-19 responses, my presentation is a bit different in the sense that, we are not necessarily talking about how the policy responses have been designed in the context of Bangladesh, but we are actually looking into how those policy responses, once designed, have been implemented at the local level. What was the role of the local government officials, the appointed officials, the administrative officials, how they managed to sort of deal with the crisis that is happening at the local level. So before moving into that, I mean, the thing is, we know that due to COVID-19, there was an unprecedented challenge, and the basic challenge was to sort of striking a balance between protecting lives and continuing economic activities. Even the strategies, the policy responses have varied across countries, but in case of Bangladesh, we have seen that the government initially decided to go for a strict enforcement, and what it did, as part of that, to sort of try to sort of keep people within home, restriction on mobility and that kind of thing, and then eventually decided, after the first wave of COVID-19 was coming to an end, to gradually open the economy. The thing is, so there is kind of a focus of the government of Bangladesh in terms of promoting economic activities and promoting livelihood, and what we are trying to understand is how the local government officials have played an important role, to that effect. So, okay. So in case of Bangladesh, I mean, the first case was detected on March 8, and the government actually decided to close the whole country, so declared a vacation and introduced several policy measures to restrict mobility. But as I mentioned, that even though that started by the end of March, by the end of May, the decisions were taken to gradually open the factories and resume economic activities. That was what happened during the first wave. During the second wave, which started in March 2021, the government decided to restrict mobility in April 2021, but this time the government actually decided not to stop the economic activities. So the decision was at the central level that we will allow the economic activities to continue, but while doing that, there will be some specific policy measures that the industries will be able to function, but they have to follow a strict health guidelines. So there is that particular focus in there. So this is what we are trying to understand, that when the focus is on promoting, a livelihood, while the focus is on, continuing the economic activities. So how did the local governments respond? How did they try to sort of, work along the directives set by the central government? And what are the factors that actually supported them in implementing the policy decisions? What are the challenges that they face? And what can we learn from Bangladesh's experiences in terms of, looking to the local government responses? So if we sort of consider that, as I say, that Bangladesh had to go through 2 different waves. The first wave, which started in March, so there was an uncertainty. That uncertainty encourages the local government agencies to focus on strict enforcement. So as a result of that, what happened is, there was a panic. No one actually knew what was going to happen. So it became easier for the local government to sort of, focus on ensuring that people stayed at home. In line with that, the economic activities eventually stopped. And there was, at the same time, the government decided to support the marginalized group through introducing different social protection mechanisms which Bangladesh had in place. In addition to that, some of the programs were kind of expanded to support more people. Once that ended by May, as I say, so the restrictions was relaxed. So even though the offices and industries initially remained closed, people did not follow the restrictions, markets started to operate, movement restriction was not followed. And within that, the second wave started in 2021. So this is where the balanced approach was actually followed. As I mentioned, that the industries remained open with strong monitoring. Markets still operate, but people were followed health-related guidelines, even though they can go to the markets. There was restrictions only on unnecessary movement. Economic activities resumed, and there was an emphasis on community-led social support. So what was the key strategy at the local government? What we have understood, what we have found in the case of Bangladesh, that the central government allowed the local government officials to exercise discretion. In terms of policy, what we can say that the decision was made at the central level that markets will remain open, but how we are going to sort of deal with that, it depends on the local context. And to sort of make a sense of the local context and implement the policy guidelines, total discretion was allowed to the local government officials. For instance, in one case, we sort of collected data from 2 different districts, one industrial area districts and another was an agricultural area district, where we see that the top level administrative officials at the district level, he told us very clearly that he was told that the government official told him at the central level that it is completely up to you. You decide how you want to sort of keep your district safe. When he decided, when the second wave was spreading, when he decided to isolate the district, he actually sort of tried to seek permission from the central level that I'm going to do that. And the response that came from the central government was, well, do whatever is necessary. If you think that this is necessary, you are allowed to do that. And at the same time, when we talk to the local law enforcement agency officials, they actually conveyed to us the same message, that the directive that they received from the central government was that you have to keep people off the street. You have to make sure that there is no unnecessary gathering of people. It's up to you how you're going to do that. We allow you that complete authority. So that particular discretion that has been allowed for the local government officials to enjoy, that played a very important role in terms of allowing the local government officials to consider the local context, to sort of think about what they have at their disposal, what sort of community support that they can derive, how they can interact with the political officials, and they're trying to sort of develop their responses considering that. And as I say, that the discretion allows the administrative officials in Bangladesh at the district, we call the deputy commissioners or DCs. They were the highest level government officials, administrative officials, they were in charge. And at the sub-district level, there was the executive officers. They were encouraged to exercise that autonomy to sort of decide what they are going to do. But at the same time, it is important to understand that the government officials, even though they had that authority, they had that autonomy, they were allowed to exercise that discretion, they were working in a coordinated way. At the district level and at the sub-district level in Bangladesh, there are 17 government departments that were at place. But what happened is these department officials actually tried to sort of work together in a coordinated way. Even though that coordination was led by the deputy commissioner or the DC at the highest level government official at the district level, he actually tried to sort of communicate with them and decide how they can work together. And at the same time, they actually took the opinions of the elected officials, the local government elected officials, the chairs, the members. They had serious discussion about that, because there was an understanding among the government officials that if we really want to reach out to the people, the elected officials and the civil society organizations are the key actors. We need to reach out to them, we need to learn from them, and at the same time how we can use their influence to sort of set the policy tone that has become a key response at the local level. So as we say that we in one of the districts, the agricultural districts, CPAN, where we have seen that the local government officials, their responsibilities were distributed, delegated, and they were sort of given responsibilities to look into some certain areas. And at the same time, what happened is the political leaders and the street level bureaucrats monitor the whole situation, and in case of violence, in case of violation that the rules or regulations regarding restrictions and others are not being followed, they actually reached out to the district level administrative officials to sort of discuss what can be done. There was a focus on ensuring coordination. What we have seen that during the time of pandemic, the local government officials used to hold online meetings. They use Zoom and other platforms to have regular meetings every night. So every night after having their daily activities and duties, they met online, they discuss what they have learned, what are the challenges that they're facing, and they're trying to sort of solve that and sort of redistribute responsibilities if necessary. And one of the things that we have learned at the same time that the informal support system, because sometimes the administrative officials, when they had to follow the books, follow the laws, they could not actually manage necessary support from the, to the people. In that cases, they relied on the political leaders' influence. In one particular case, we have learned that there was a shortage of oxygen cylinder. The administrative officials could not manage to do that. So they reach out to the local political leaders and ask them, well, can you help us? So that political leader used his connection at the central level and managed oxygen cylinders for the people right there. So that kind of informal understanding and knowledge sharing, information sharing was actually going on, which played a significant role. And at the same time, in case of industrial areas, what we have seen that the local government officials played a significant role in terms of keeping the industries open. And again, this is where the coordination and reaching out to the civil society organizations, the trade unions and others become important. For instance, in one particular area, even the industries were opened up, there was no transportation facilities available for the workers to come to the industries to work. So when that information reached out to the district level official, they reached out to the transportation workers, the transportation owners, and told them that, well, we need this support. There will be financial and other support from the government to the transportation level, transportation sector workers, if they decide to support the industrial workers. So that kind of connection was actually building on, and which played a very important role. We have also seen that there was significant effort to support the vulnerable groups. And this is where we have seen that sometimes when the social protection level support was not available, there was community level resource mobilization was going on. In the industrial areas, the district level officials reached out to the industry owners and said that, well, we need to support those people. So let's contribute and let's see how we can work. In other areas, we have seen that where the other professional groups are not necessarily being able to cope up with the situation, there were financial support was made available to them. In terms of local business, there was a creative solution that was allowed. In one of the districts, which is kind of the agricultural area where mango production is the key, we have seen that, since due to restriction and others, mangoes were not necessarily being transported to the through the formal channel. So what the local administration did, they tried to introduce a special mango train. In a particular period of time, there was a train service which was introduced only to sort of transport mango from that district to the other districts and the capital city. So that particular system was introduced so that the economic activities continue. And interestingly, that mango train is still continuing. There was a focus on shifting the markets to an open place, and this is where the political actors' role were significant. At the same time, when there was significant restriction on mobility, there was the agricultural Department of Agriculture actually created opportunities so that agricultural labor can move from one district to another district. So this is again is an outcome of the discretion that the department officials were given that opportunity, given that authority to decide how we can solve that problem, and they kind of have the discussion among them and try to solve that problem. So this played a very important role. So what were the enabling factors? So how did this discretion actually work? The first thing is the political environment, that the government had a trust-based relationship on the local government officials, especially the bureaucracy. And this is where Andrew was talking about the political dynamics. This is where the political dynamics of the country becomes important. In a country like Bangladesh, where the bureaucracy is extremely powerful and has become extremely powerful over the years, so this delegation of authority to the local government officials played a very important role. But having said that, the government officials, the administrative officials, they also decided to work with the local political leaders in an effective and efficient manner. At the same time, discretion was complemented by engaging the citizens and framing the problem. There was effective effort to interact with the political leaders, and there was that effort of network building that we were talking about. So what is the lessons? The lessons is you can allow the local government officials to exercise discretion, but in order to have the discretion to be properly utilized, to ensure that they are on the same page, it is important that they develop a sense of common purpose. We have seen that in some districts, in some areas, that sense of common purpose was well developed, which played a very important role. But in some cases, there were, as Andrew has already mentioned, that it's not always an ideal scenario. So when the common purpose is missing, there can be some discrepancies, and this is where the monitoring and accountability issues become important. And it also, Bangladesh's experience also shows that it is important to identify and engage and work with different stakeholders. If the government agencies try to sort of solve those problems on their own, instead of involving the local level actors, we probably would not have seen the response that we had seen during the COVID-19. So they need to know, and they need to sort of work with the non-government actors, which is very important. And this is important, that we know that the government works in a hierarchical structure, but different studies have already shown that in a time of crisis, this hierarchical managerial structure may not always work. We need to work through and what we say hierarchy or collaborative network management. And this is where it is important. This network management can play a very important role during the time of crisis when everyone needs to be on board. And the final point is the local socio-economic context we need to taking under consideration. So there cannot be a single uniform plan. So for industrial areas, there can be some certain plans, as I say, that when we're talking about isolating a district, it was easier for the agricultural district to do that because there were only 3 entry points within that district. So if you can stop that entry points, you can isolate the district. But for an industrial district, there are multiple entry points. So you cannot do that. So you need to create the economic opportunities, but focus on maintaining the health guidelines and everything. So that local socio-economic political context is very important to sort of, introduce and design implementation plan. So that is all from me. I think I have succeeded in maintaining the time. Thanks, everyone. Thank you.
Thank you very much indeed, Dr. Shahan. Very interesting. So we've heard from 3 country contexts. Have there been some reminders to everyone listening? If you'd like to put a question in the chat or the Q&A, you're very welcome. I see there are 3 interesting questions already in the Q&A. So perhaps presenters could, if you are so inclined, perhaps even have a look at those questions already, and you might like to perhaps give some written responses while we're still listening to more of the presentations, which would be great. So without further ado, let's now hear about several reports which have also been produced, which I think are going to provide us with some more illumination. And Dr. Vidya Diwakar, if I can turn to you first.
Great, thank you so much, Peter, and thanks to all. As Peter mentioned, Andrew, Shepard, and I here today are delighted to introduce to you the Chronic Poverty Report on Pandemic Poverty. This is a team effort of a range of researchers and writers, designers, project and comm supports, backed by the COVID Collective at IDS through the FCDO. So in introducing the Chronic Poverty Report, you might be asking, what is the Chronic Poverty Report about? It's about learning from experiences of people like Aisha here on the screen, who was caught between the COVID crisis and crisis wrought by the negative consequences of policies delivered in response to the pandemic. So in Aisha's case from rural Bangladesh here, contributing to her family's income loss, ill health, and so forth. So our effort here is to learn from cases of impoverishment as well as sources of resilience to help identify a better balance of policies to help mitigate the negative effects of the pandemic and its intersecting crises on people in and near poverty. And in fact, our research found more broadly that where restrictions were sometimes less stringent, where markets, for example, continued to operate, as we just heard from Asif, where mitigation measures were present, a degree of absorptive and adaptive resilience capacities could be maintained that enabled people to either recover more quickly or to remain out of poverty. So this then leads to the question, what might these mitigation measures be? On the economic policy front, for example, this life history from Cambodia, which we've heard about today as well, from Andrew, illustrates the importance of, in Dara's life, the importance of factors like microenterprise development, gifts, including assets like land, but also business declines during the pandemic. Yet we see that in terms of the policy response during the pandemic, most countries did relatively more in terms of macroeconomic management than in terms of microeconomic management. And of course, this is not to downplay the importance of macroeconomic management, which is quite critical in disaster responses, as we've heard Andrew speak about in the case of Cambodia, Her Excellency in the case of Nicaragua as well. And these macroeconomic responses might include the ability to roll out expanded social protection and so forth, wage subsidies, health and education measures, vaccine programs, keeping markets open, and so on. But equally important to this macroeconomic response is keeping microeconomic policies or programs ongoing. So, for example, measures that are not only growth enhancing, but also poverty reducing, as we just heard about from Asif in the case of Bangladesh. At the same time, we note from the pandemic that there's still stronger scope for in-crisis household debt management, as Andrew drew attention to. Another challenge as well during the pandemic is that there were considerable damages to people's long-term ability to escape poverty. And this was primarily through harming intangible assets, for example, like education. And I draw attention to education here because we know it's from our previous work on education and poverty dynamics that it's quite critical in driving sustained escapes from poverty. And in fact, this life history from Zimbabwe highlighted a case where completion of primary levels back in 1990 helped the respondent Mercy achieve a degree of resilience and diversification as well, while her daughter's salary and teaching also helped then in mitigating some of the negative impacts of the pandemic. But we know, of course, during the pandemic, as shown in this graph on the left, is that many low and lower middle income countries had particularly long school closures, and along with that also had low school feeding rates as somewhat otherwise partial mitigation measures. We also know, for example, that connectivity problems were significant, especially in low-income countries, as the spider diagram on the right shows. And in many cases, digital education just didn't work. In other countries, we also know, however, that school closures were kept to a minimum, Nicaragua being one. So there was, of course, considerable variation as well. But in this context, where remote or digital education was seen as the primary policy response to enable education access, we also need to consider the role of professional development, for example, to teachers, to enable them to implement alternatives. So this table on the left summarizes some multimodal approaches for different levels of connectivity. We heard already in terms of Cambodia, small group learning that was tried out. In Ethiopia, cases of village level resource mobilization as well to support some of the poor students in specific sites. So there were some responses as well to varying degrees of success that could be built on in future crises. At the same time, as widely recognized, we're in a period not just of the pandemic or recovery from the pandemic, but rather in a period of multiple intersecting crises, as observed in this life history from Hassan in Afghanistan. And This is crises of, for example, the pandemic, ill health, the policy responses, insecurity, climate-related disasters, and so forth. And in fact, this chart, what it does is it plots the number of people affected by climate-related disasters against the number of people affected by fatalities due to violent conflict or protests during 2020 to 2022. And what we see is especially a convergence in the top right, especially in certain low-income countries, which had a large number of people in poverty prior to the pandemic as well. But when we consider responses to multiple intersecting crises, to polycrisis, we largely see two pre-existing approaches to their response. One is around the HDP nexus. I realize we're short on time, so I'll just highlight that broadly, there's been quite little operationalization of this. Also happy to chat about this more during the discussion. A second response was in terms of integrating conflict into disaster risk reduction strategies. So the example on the right here is from during Cyclone Amphan in India and Bangladesh in the summer of 2020, where a composite risk matrix was developed to design a multi-hazard programming response that considered both parameters of the cyclone as well as the pandemic, and where, for example, the risk of the pandemic's transmission was high, we saw shelters being half full to facilitate social distancing and so forth. Finally, we can also consider social protection as a response to polycrisis. And in fact, it was the major response to mitigate the negative socioeconomic impacts of the pandemic itself. Yet at the same time, we see from other analysis that often additional assistance was either delivered as a one-off or it was stopped in 2020 itself, despite the presence of subsequent intersecting crises as noted. Of course, again, one of the exceptions here, and we draw attention to several exceptions in the report. One such exception was in Cambodia, where the social assistance programming was extended to, for example, people experiencing floods and inflation into this year as well. Ultimately, then, what we argue for in this chronic poverty report is for context-specific rather than global responses, for stronger support and power to local governments who might recognize and be able to respond to their context more effectively, as well as for greater pre-crisis investments in building resilience at systems level, as well as of individuals and households, all within sound macro and microeconomic management. This is, of course, no easy task, but one which can reap enormous dividends for current and future generations in the path to zero poverty. Thank you.
Fantastic, Vidya, thank you. And it's really interesting to hear how the report mirrors to some extent some of the lessons that we've also heard from the country studies that we've just been listening to, which is great, thank you. Now, let's go quickly on. Catherine Grant, Research Officer at IDS, to speak about the People's Agenda on Pandemic Preparedness. Catherine, over to you.
Thank you very much. I'm going to talk about the People's Agenda for Pandemic Preparedness. And this report was supported by the COVID Collective. Contributions to this report were received from over 50 researchers from 25 countries across 6 continents, and some of them are joining us on this call today. Following on from a COVID Collective event in March 2023, where the idea for this work was conceived, we formulated several questions that would help us write a People's Agenda for Pandemic Preparedness. These were based on what we felt was most important to collect data on and information that may be unpublished, but that could contribute towards understanding what's needed for future pandemics. We asked researchers from several networks and projects, which are listed on the slide, to answer these questions and co-write this report. We also advertised this opportunity on IDS Twitter, Facebook, and LinkedIn accounts to enable others to contribute. So why is this important now? Well, in May, the WHO declared that COVID-19 is no longer a global health emergency, and we feel that now is an important time to act, reflect, and make plans for future pandemics. In this new period, pandemics are still a threat, and the aftermath of the emergency and the restrictive policies to mitigate it still need to be dealt with. Reflecting on the lessons learned during this period can help formulate better policies for the future. There were several resounding lessons which emerged from across the globe that seem to be at the root of many issues. raised. These included resolving systemic issues such as creating strong health systems, ensuring that the most vulnerable were supported, increasing community involvement, and taking pandemic innovations forward for the future. Of particular relevance for this event, COVID-19 pandemic has disproportionately affected vulnerable, marginalised and disabled populations, including those experiencing poverty. They were less able to adapt, had less of a safety net available to them, and the informal sector suffered as this work could not be moved online. To recover from the problems brought about by lockdowns and restrictions, a range of support is required which embodies a holistic approach that addresses the multifaceted needs of individuals and families. The impact of the pandemic varies greatly and ranges from direct impacts on the economy and jobs to indirect impacts, such as loss of learning for children and young people. Actions which were highlighted in the report, most related to pandemic poverty, include a need for increased support for vulnerable, marginalised and people with disabilities who often had issues accessing assistance, support for children and young people whose life path was derailed by the pandemic, and increased social protection, livelihood recovery and sustainability were often compromised by a lack of sufficient and effective social protection measures. So the first question we asked was what do people who are experiencing poverty or vulnerability need to recover from the problems COVID-19 brought and the policy responses to it, for example, lockdowns, restrictions and other measures. Despite responses coming from across the world, most responses highlighted a lot of the same issues and needs of their people. These are shown on the slides, and I'm just going to focus on one area which is most relevant to our discussion today. Almost all researchers mentioned the importance of support for economic recovery and protection of livelihoods, especially for the most vulnerable, marginalised, poor and disabled. The pandemic enhanced many of the pre-existing vulnerabilities of people, and they suffer both immediate and medium-term economic losses in income, employment and savings. It also negatively affected their ownership and control over assets, financial autonomy, access to resources and access to health services. Many people experience poverty, job losses, reduced incomes and restrictions affecting their livelihoods. One example is some research conducted by the International Centre for Research on Women on informal women workers in India under the Rebuild project, which found that 87% of women borrowed money during the first phase of the lockdown, but only 6% borrowed this from formal financial institutions. They reported having to mortgage jewellery or homes, and many continue to be in debt. They were also heavily dependent on government relief to manage the financial aftermath of the pandemic. Financial assistance such as unemployment benefits or direct cash transfers can help alleviate economic hardships and ensure basic needs are met. The second question we asked was what support did people receive during the pandemic and who was this from? And it came from a range of places, as you can see on the slide. Support was provided to poor and vulnerable populations from governments and other organisations, but many actually received no support, or there was issues around the type or the amount of support received. It's worth noting that there were also challenges in the implementation and distribution of support measures. For example, some individuals and communities faced difficulties in accessing support due to issues such as discrimination, bureaucracy or inadequate infrastructure. Researchers mentioned a lack of transparency or hoarding relief items or drug shortages for existing medical conditions. There were also issues mentioned with how support was provided in some areas. So policies need to be thought through so they can have the maximum benefit. Some other research from the Women in Informal Employment found that relief measures declined between mid-2020 and mid-2021, and they did research across several countries, including Thailand, India, Ghana, Senegal, South Africa, Peru, Mexico, the USA and Bulgaria. So it was across a range of different continents. And other key issues and barriers for accessing loans included low awareness raising, complex online application procedures, digital illiteracy barriers, and even hesitancy from workers to take out loans, fearing they would be unable to repay the debt. While relief measures helped cover household expenses, they were insufficient to cover the economic losses experienced by informal workers during the crisis. Nevertheless, it should be noted that there were important country and city level differences, and there were some examples from researchers in several African countries that mentioned support being politically motivated or not being distributed fairly. So I'll just go on to the last question which we asked, which was what do you think needs to be done differently next time and by who in order to be better prepared for the next pandemic? And the most common responses to the pandemic included schools closing, travel restrictions, bans on social gatherings, emergency investment in healthcare, new forms of social welfare provision, augmented health systems, and management of economic consequences of these actions. I've outlined responses to researchers on the questions of what needs to be done differently on the slide, for example, better communication, increased technological innovation. Pandemic preparedness plans could have been more effective in many countries, especially when considering the needs of vulnerable, marginalised and disabled populations. Many approaches were top-down and biomedically dominated. The researchers contributing to this report suggested social, economic and political priorities which will contribute towards future preparedness, which consider local context, populations and needs. It was also suggested that involving communities and ensuring their participation in the mapping of vulnerabilities for preparedness and in the process of following up regarding the distribution of food support and emergency funds would ensure more targeted and useful support. So to conclude, this report was gathering together responses from around the globe, and it's important to look at these issues now because in May, the WHO declared that COVID-19 no longer represents a global health emergency. It also warned that the worst thing that any country can do now is to use this news as a reason to let down its guard, to dismantle the systems it's built, or to send messages to its people that COVID-19 is nothing to worry about. Now is an important time to act and reflect, and we've entered into a new period of dealing with the COVID-19 virus and should consider and collect these lessons learned from around the world to enable us to better prepare for future pandemics. So over these 50 researchers from 25 countries across 6 continents shared key lessons that they found during their research in their countries. Not all of this knowledge gained and information about the impact of different policies has been published. So by gathering the information in this report, we can ensure that learning is not lost and is collected together to provide evidence for the next pandemics, improve preparedness plans and enable learning about which policy decisions were successful and how to improve in future. The future of pandemics is uncertain, but we can plan for this uncertainty by building our capacity for developing appropriate solutions and ensure countries and institutions work together to share diverse perspectives and develop solutions based on mutual learning and knowledge. Thanks very much for giving me the opportunity to talk about this report, and I look forward to discussing it with you further.
Thanks, Catherine. Great. We have one final presentation, which is a pre-recorded one. So if I could ask my colleagues to load up the presentation from Professor Toby Green from King's College London.
Good afternoon, everybody. My name is Toby Green, and I'm a Professor of African History at King's College in London, in the UK. And it's great to be able to participate in this event organised by the Institute for Development Studies. I'm sorry I can't be with you at the actual moment of the presentation, but I'm grateful to you for watching this pre-record. And I'm just going to share my presentation with you. So what I'm going to talk about today is the outcome of a conference which I helped to organise at King's College London at the end of April this year. The conference was called The Impact of COVID Restrictions in Low and Middle Income Countries. So it deals very much with the theme of this panel around poverty and the relationship between poverty and the pandemic, and particularly, of course, with the pandemic response. So this was a conference which took quite a while to arrange, because we had a range of speakers coming from around the world. Countries represented included Angola, Argentina, Bolivia, Cape Verde, Colombia, Ghana, Guinea-Bissau, India, Kenya, Mozambique, Nicaragua, Nigeria, Turkey, and Vietnam. We met for 3 days. On the first 2 days, we had a series of presentations from our colleagues from around the world. And on the final day, we divided into different working groups to come up with recommendations building on the discussions that we had in the previous 2 days. Now, the vast majority of colleagues attended in person, as you can see from the photograph here, although that we did have a couple of Zoom presentations as well. So the 4 working groups that we had on the, working on the final day were as follows. One was on the impacts of restrictions, lockdowns and human rights. The second was on global institutions, community health and education. The third was political authoritarianism and public opinion, public discourse in the COVID pandemic. And the fourth was pandemic preparedness, plans and alternatives. So what I'm going to do is take you through each of those working groups and the presentations or the conclusions which those groups drew. And then towards the end, then think about what this says about how in future health emergencies, the enormous increase in poverty, and impacts on human rights, education, other medical needs in countries around the world, how all of those impacts could be lessened, and what lessons that the conference as a whole drew from from the discussions and from the experience of the COVID pandemic. I should say that the participants were from a range of different disciplines. We had medical professionals, we had people with long histories of working in the NGO aid sector, in healthcare. We also had economists, political scientists, and people who work with human rights and public health more generally. So it was a very wide range of participants in this event, and these were the conclusions that were drawn. So the first group, as I say, was looking at the impacts of restrictions, lockdowns and human rights. And their core findings were, as we see, that first, there was an initial risk of spread of a new virus for which no remedy was immediately available. However, secondly, universalism in the implementation of lockdowns in low and middle income countries took place outside of the context of the disease's epidemiology, outside of the context of local socioeconomic, cultural and particular health systems, and indeed the unique contexts of each country. Therefore, thirdly, the lockdown as applied resulted in huge collateral damages, and a reconsideration of the processes of implementation and enforcement is critical in future pandemic management. So really you need to reconsider the way in which policies of lockdown were implemented. So lessons learned included the need to A, contextualize lockdown across geographic disease risk settings and peculiarities before imposing them. Secondly, and most importantly, in some ways, a bottom-to-top approach with community engagement critical at all stages rather than a top-down implementation. Thirdly, communication of accurate, honest information and messages on reasons for restrictions being imperative, with options with less collateral damage always being considered and enforced where possible. Fourthly, open and inclusive public engagement and debates, including disadvantaged persons, must be done before any restriction is proposed in the future. And finally, that low and middle income countries should develop their manufacturing base for production of essential products and commodities in healthcare services. One of the issues being that the disruption of supply chains caused by global lockdowns caused enormous impact in provision of other vital medical supplies, including, for example, malaria rapid tests. That was the first group. The second group was looking at global institutions, community health and education. This group's core finding was that the pandemic response cannot be seen in isolation in national or historic terms. It must be understood holistically as a global event in which the working dynamics of international organizations faced a stress test and largely failed. And this requires rethinking organization and funding of global healthcare and of education. Recommendations included, firstly, that international organizations must build an understanding of diverse contexts into policy making. Secondly, that aid conditionalities can be harmful in shaping crisis response. Thirdly, that representation from LMICs and their voice in international forums and global institutions like the WHO and the World Bank is vital. Fourthly, that individual nation states must develop and implement plans which are customized for their own contexts, building on past experience. And finally, that the social experience and mental health of youth and children must be considered in any medical emergency. The very many issues with education, where in a variety of countries such as Honduras and India, schools were closed for almost 2 years, meant that there was a collapse in education for hundreds of millions of youth and children. So school closures are widely recognized to have been disastrous, and policymakers needed to take more account of questions such as balances of disease risk, social experience and mental health, alongside associated risks of school closures, such as forced marriage and child labour in low and middle income countries. The third group looked at political authoritarianism and public opinion or public discourse in the COVID pandemic. As you see, the summary said that what we saw was that the COVID-19 pandemic accelerated the pre-existing trend towards authoritarianism. Policymakers granted emergency powers to the state and to the security apparatus and manipulated public opinion to support these authoritarian measures. The pre-existing trend towards authoritarian rule had its roots in a pushback from the more privileged sections of society against liberal democracy and the welfare state, paralleled by the growing power of corporate capital over national governments and global institutions. And therefore, this group concluded the pandemic offered an opportunity to push through pro-corporate measures that both curbed labour rights and abridged freedoms, especially of working people, migrants and all marginalised sections of society. So this group was especially critical in the way in which this took shape through the role of public health advice. The poor quality of public health advice had devastating effects on public trust in healthcare, and this, of course, could have catastrophic future impacts. Firstly, much of the messaging took the form of a sort of theatre, dramatising and overemphasising irrelevant and ineffective hygiene measures. Secondly, that the effective measures that could have been taken and should have been taken were often lost in a long list of personal safety measures, many of which and most of which couldn't be implemented by the majority of the population in LMICs. There was little focus, thirdly, on identifying the appropriate mix of message, medium and communicator. There was widespread victim blaming, whereby the government and elites shifted the responsibility of illness and death onto individuals rather than the policy response itself. And finally, there was excessive emphasis on enforcement through punishment and penalties, leading to stigma and denial. In sum, we could say that a decade or more of the shift towards authoritarian corporate capitalism made an increase in political authoritarianism the default response, and this had highly negative outcomes. The final group looked at pandemic preparedness, plans and alternatives, how to think about the lessons of the COVID pandemic for future medical emergencies. The core finding here was that the best approach to pandemic preparedness involves consistent public investment in healthcare and social protection throughout, regardless of whether this is during a pandemic period. In healthcare, the focus should be on strengthening primary care and human resources. This should be balanced with investment in secondary and tertiary care rather than higher cost alternatives of investment. It is this approach which can ensure that health systems do not need to be restricted at times of crisis, meaning that the negative impacts of delays to routine medical care don't create health emergencies long after the pandemic itself may have passed, which of course is sadly what we're seeing in many countries around the world, as conditions which weren't treated and are crucial to daily life and endemic health problems got much worse. On the other hand, social protection systems need to be strong and designed or redesigned to allow flexibility to expand in terms of coverage and depth in a crisis. In summary, first, health systems require built-in redundancies to deal with emergencies. Secondly, lengthy sustained public investment in social protection leads to better health outcomes rather than an emergency response. Third, during health emergencies, there must be a balance between using the decision-making capacity and resources of central or national authorities on the one hand, and the on-the-ground organisation and expertise of local authorities on the other. And finally, pandemic plans and general health preparedness must allow for the disaggregation of risk and the awareness of different levels of risk faced by different sectors of the population and how those vary from country to country. So to conclude, many of these themes were overlapping, and there were, of course, areas of disagreement among the participants in this event, but the broad conclusions of the working groups were clear, and their common themes essential in mitigating health emergency which emerged were the centrality of public investment in healthcare, especially primary healthcare and infrastructure, and in social welfare, which can expand then at a time of need, proportionality and the disaggregation of risk, the centrality of human rights and local actors' knowledge and experience, the importance of an open and accurate flow of information, attendance to socioeconomic factors and the social determinants of disease, awareness of the complexity of supply chains and the impact disruption can have in access to healthcare, and finally, awareness of how policies that aggravate inequality will exacerbate ill health. And these must be central building blocks to preventing poverty and long-term poor health outcomes in any future pandemic. So I'm very grateful for your attention. Thank you very much. The full report is available at the link there. And I wish the rest of the panel and the session to have a constructive discussion. Thank you very much.
Great. Well, thanks to Professor Toby Green for that pre-recorded video. And we've had some really interesting presentations, a lot of information, country context and reports on dialogues and conversations which have taken place with a lot of, I think, overlapping areas of interest, but also some quite distinct points. And I'd just like now to finally invite our two discussants, Bushra Ebadi and also Dr. Konan Michel Yao, to share 5 minutes each, if you wouldn't mind, just your takeaways and perhaps some insights as to where you think there will be priorities or particular challenges that will need to be addressed in regard to what we've heard today. So Bushra Ebadi, may I come to you first? Thank you.
Thanks, Peter, and thanks for inviting me to reflect on the insights that were shared today. I think across the different cases and the reports that were shared with us, I found that there was a strong emphasis on the importance of local engagement and policymaking, that you can't have this, I think, detachment between the different levels of governance, that we need to be thinking about this more systematically. And we need to build and invest in not only the systems themselves, for example, healthcare systems, but also in trust, institutional and sectoral capacities and capabilities, and then also community engagement. That doesn't just start during a crisis. It needs to be built before we're in the middle of a crisis. And unfortunately, at the moment, we're experiencing converging crises. So it's a little bit like we're trying to build the plane as we're flying it in some cases. And I think that metaphor is also problematic in some ways, because it's just this reactionary response instead of thinking about what the enabling environment looks like. As I said, we're not just facing one crisis at a time. I think much of the responses to the pandemic were focused initially on the context where we didn't really have robust protections for people. We're focused just on the health aspect, but in fact, we're facing multiple crises at the same time, and so need to have, sorry about the background noise, we need to have considerations for these other aspects as well. And that our mainstream systems are not currently fit for purpose. And so one of the key priorities for me in terms of action coming out of this is going to be not just responding to crises, but really collectively working towards developing better, more robust systems, and taking some of these lessons that we've learned from these contexts, including the investment in educational systems, social systems, and protection in particular, as well as our public health systems, that shouldn't just be a reactionary endeavor, but something that we extend into a longer period of time, and then also need to keep in mind that the political will and the political influence as having a really important impact. And then for future challenges, or the main challenges that I foresee, is that most of our responses to crises tend to be, again, focused on one specific aspect, and the way that we're responding right now is exacerbating other crises and hindering our ability to promote sustainable development writ large. For example, some of our priorities when it comes to digitization and the push for maybe just using digital technologies as the solution instead of just as an enabling tool, it can also harm our ability to respond to climate crises. Just the sheer amount of energy that's being used, or the resources that are being put into digitalization globally, needs to be really seriously considered, because it does also have impacts on our ability to respond to these other crises that we're facing currently, but also that will be coming up in the near future.
Thank you, Bushra. I wasn't sure if you'd concluded, but that's fantastic. Thank you. And I realize you're competing against some background noise as well. Very clear and very helpful indeed. Thank you. Dr. Michel Yao, over to you for your thoughts.
Yeah, thank you very much. And quite a great presentation from countries as well as also different report. My takeaway on the first point related to what should we learn is that preparedness at least should be part of also the normal systems. It could be the health system as well as surveillance, and also medical supply chain and others. Secondly, the takeaway is about coordination, including a different level in the country structure, down from the community up to the highest level. This multi-sectoral coordination make a difference in making a decision to address a public health issue. So then all the different components, including what we can call side effect, can be managed effectively when this is done through a multi-sectoral coordination, what was presented also by the country. A community-based approach, as well as also mitigation of the health impact, the health measures, public health measures, is also critical, including continuous consideration of the social support to vulnerable people is quite important. And this should be tailored based on the country specificities. This is also one of the things that we learned from the reports, as well as also country presentation. Now for action, what could be the priority action based on what we just learned? Of course, a new global health governance is maybe required, taking into account all these different aspects. We learned that it is not only health people that should manage health crisis, but they should include all the different components, including also preparedness, in multi-sectorial preparedness, that is also required. Right now, we have discussion going on, a group working on the international health regulation, as well as another group, intergovernmental negotiation body working on an agreement, what we can call also a treaty, taking into account different components, including community protection, the issue related to equity, human rights, and others. Collaborative surveillance, it was mentioned, the issue related to One Health, so that at least public health threats can be quickly be detected and also act on. Coordination, including National Public Health Institute with all the different determinants of health, what affects the health of the people should also be considered, including community or economical impact of public health issues, as well as the workforce. The health system, it was also mentioned in the presentation, how can we build a resilient health system that can be scaled up when we have a major crisis, emphasizing on primary healthcare, as was mentioned in one of the report, and also the last point, access to countermeasures, research and development, innovation. How can we collectively work on it so that at least result of research or innovation can be accessible to all the different countries? But we still face one of the major challenges is investment out of the crisis period. When it comes to preparedness, at least political or maybe decision makers are a bit slow in investing in preparedness. So it's one of the major constraints we hope maybe the treaty will address. The whole government and whole society preparedness, because out of the crisis, there is a working silo that required a kind of continuous work in the peacetime, so that when a crisis arises, this can be more effective. And then lastly, effective readiness that can help us to move forward. We should test continuously our different mechanisms in health, but also out of health, to make sure that if a crisis arises, this system will be responsive and will be effective. Thank you very much.
Thank you very much indeed. I really appreciate your comments, both from Bushra and for Dr. Michel Yao, just helping us make sense of this very rich tapestry of experiences, findings, and knowledge which has been shared in this session. Now, time really has beaten us in terms of being able to open up for a further discussion. But just to say, there were some questions that were posted in the chat, and thanks to our colleagues, some of them have already been answered, and the question and the answers are already there. There is also an email contact address in the chat, chronicpoverty@ids.ac.uk, and that is an opportunity that if you have further questions or comments that you would like to share, you're very welcome to write to that email address, and it may be possible also to invite some of our panelists to help with responding to some of those points that you would like to make in the future. We've heard some really important and interesting discussions today, and reports as well. Again, the links to those reports are in the chat. I think some of the key things which come out for me from listening to both the country examples from Nicaragua, from Cambodia, Bangladesh, and now also for the reports, and also to our two discussants, is that ultimately, in terms of readiness for the next pandemic, because I think we should not fool ourselves, there will be another pandemic. The question is only when, not if. We will need strong, agile health systems, and that is going to need investments, as Dr. Yao has just shared. We will need to really target those who are most vulnerable. We will need to be really engaging with communities, but other societal stakeholders. And also we need to learn from and use the innovations, many of which have arisen within communities, but in a host of other settings as well, which will help to guide us in actions for the next pandemic. But preparedness means about being ready now. We heard that warning cry, not to assume that because the official pandemic end has been announced, that means now we should just move on to other things. There are multiple intersecting crises at play, but we need to be ready and to maintain our readiness. So it's been a really great discussion. I must thank all of our presenters, Her Excellency Dr. Reyes Alvarez, Andrew Shepherd, Dr. Asif Mohammed Shahan, Dr. Vidya Diwakar, Catherine Grant, Professor Toby Green, our discussants, Bushra Ebadi, and Dr. Michel Yao. Thank you to you all. Thank you to the IDS team for organizing and facilitating this. Thank you to our interpreters, who, as always, enable us to understand and make sense of the world through their voices, and to the organizers of the United Nations HLPF for enabling us to come together in this space. We invite you to continue engaging in this important discussion, and we invite your ongoing participation in exchanging knowledge and learning going forward. Please do keep in touch, and thank you again for participating today. Goodbye.